Collier.
Here.
Busey. Here. Schofield.
Schaffner. Here.
Schofield?
Schofield.
Schofield, sorry. Jones.
Present.
Johnson.
Here.
Olcott.
Here.
Cunningham.
Here.
Schaffner.
Here.
Pearson.
Here.
Simmons.
Here.
Quorum is present. Well, good morning and welcome to the first meeting of the House Committee on Public Health for the 89th Legislative Session. I'm excited to have the opportunity to work with each member of the committee and grateful to Speaker Burrows for his confidence in me to serve as chairman. This role is both a privilege and a responsibility, and it's one that I take on knowing the urgent challenges before us. But with those challenges come real opportunities to drive meaningful change. Public health is not a partisan issue. It's a Texas issue. Every Texan, whether in our largest cities or our smallest rural communities, deserves access to care, resources, and the opportunity to live a healthy life. We're facing a mental health and substance abuse crisis that affects families, schools, workplaces across the state. In particular, our children are in distress. Rates of depression, anxiety, and suicide are rising. Our veterans, who have sacrificed so much for our country, continue to battle PTSD, substance use disorders, and barriers to care that should not exist. Substance abuse continues to devastate families and communities. Fentanyl overdoses have reached record levels. The ripple effects of addiction reach every corner of our state. Maternal and pediatric health are also pressing concerns. Texas has one of the highest maternal mortality rates in the nation, and too many mothers and babies, especially in rural areas, lack access to consistent, high-quality care. And of course, we see outbreaks of diseases that we thought were relegated to the pages of history, hospitalizing and killing some of our youngest Texans. But even as we acknowledge these challenges, we must recognize the solutions within our reach. I look forward to learning about these solutions through this committee. We have hard work ahead, but we also have the expertise, the passion, and the commitment to build a healthier Texas. Members, I look forward to working with you, and I look forward to working with the healthcare professionals, advocates, and most importantly, the people we serve to find real solutions. As we begin our work, I would like to introduce the people who will be helping us accomplish our goals this session. Our committee clerk is Scott Crownover. Assistant clerk is Alex Maldonado. And from my office, Trish Conrad is chief of staff, and our policy director is Aaron Taravella. Members, are there any additional comments before we begin our agenda? Very good. We will only be taking invited testimony today. If you are testifying, please make sure you have filled out the electronic witness affirmation form on the registration kiosks in the hallway. Today we'll be discussing several general items that relate to our committee. We have invited testimony to begin with the Texas Department of State Health Services, the Health and Human Services Commission, and then we will hear from a few other invited witnesses. We'll begin our meeting this morning with a report on the measles outbreak in the South Plains and Panhandle area with the Department of State Health Services. Members, I want to let you know that we also have a couple of resource people in the room. We have Blair Walsh, who is the Assistant Agency Director from TDM, and Alejandro Delgado, Deputy Commissioner of Operations from TEA, will be here as resource witnesses. At this time, Chair calls Dr. Jennifer Shuford. Dr. Shuford, please state your name and position. Since this is an organizational meeting, you will be classified as neutral concerning your testimony.
Thank you, Chair Van Dever. I'm Dr. Jennifer Shuford. I'm Commissioner at the Texas Department of State Health Services. Thank you so much for inviting me here today to give you an update on what's going on with measles, especially in the Panhandle and South Plains region. believe you have a handout in front of you, and I'll be going through those slides today. And I'll start with background. So measles is highly contagious. It's probably the most contagious virus that we know of. It's spread by respiratory droplets, like flu or COVID is, but it's also spread by the airborne mechanism, much like tuberculosis, where measles can hang in the air like tuberculosis does, and it can hang in the air for hours. So we know that measles can stay up in the air for up to 2 hours and be contagious over that period of time and can infect people who enter into that airspace. Up to 9 out of 10 susceptible or unvaccinated people will become infected if they're exposed to that measles virus, so it's very contagious. The best protection that we know of against measles is the mumps, measles, rubella vaccine, or MMR. So this vaccine provides really long-lasting protection against all strains of measles. And the MMR vaccine has been in use in the United States for over 50 years. So it's got a long track record. I'm going to the next slide, which talks about measles symptoms. So with measles, once somebody gets infected, there is a fairly prolonged incubation period. It's about 10 to 12 days, and then they start to have symptoms. And those early symptoms include kind of a moderate fever, cough, runny nose, red eyes, and sore throat. So it starts to present like a respiratory illness. And then after a few days, those infected individuals will get a higher fever. It can go to 104 and 105, be really high. They'll start to get that rash that's classic for measles, where it starts usually up on the hairline and then travels down the body. It kind of is red and then turns red-brown. And as I mentioned, it takes about 10 to 12 days before any of those symptoms starts, and it takes about 14 days before that rash starts. People are infectious from 4 days before that rash starts to 4 days after that rash starts. So one of the reasons why we're so concerned about measles is that there are complications that come frequently with measles infections. So they can cause serious health complications, especially in children under the age of 5, and really in those that are under the age of 1, pregnant women, and people who are immunocompromised. And so when we look at all the people who get sick with measles, about 1 in 5 will need to go into the hospital. So about 20% will be hospitalized. About 5% will get the complication of pneumonia. And rarely measles, it's about maybe 1 in 1,000. Measles can cause swelling of the brain, encephalitis, and can cause long-term neurological complications from that. It can also cause death. About 1 to 3 in every 1,000 people who get measles will die. In addition, for pregnant women, it can cause pregnancy complications like premature birth and low birth weight. There's data that also shows it can cause miscarriage. So let me talk a little bit about specifically what's happening in Texas right now. On January 30th of this year, we announced 2 confirmed cases of measles in Gaines County. Earlier in January, 2 measles cases occurred in unvaccinated residents of Harris County. So y'all may have heard about those. Those were travel-related cases and didn't spread to anybody else. And so that is separate from the outbreak that we've got going on in Gaines County. And so the cases in Gaines County related to the outbreak I'm talking about started near the middle of January, but it was diagnosed and then announced at the end of January. So, and these were the first cases that were confirmed in Texas since 2023. Now, both of those initial Gaines County cases were hospitalized, and they recovered and then were released from the hospital. They were both in school-aged children. They were from Gaines County, but were hospitalized in Lubbock, since a lot of people do seek their health care in Lubbock. That's where these initial cases went as well. Since these initial cases, an outbreak has continued in the South Plains and Panhandle regions of the state. So DSHS has a regional office in Lubbock. We're continuing to support the South Plains and Panhandle communities in coordination with the South Plains Public Health Department and the Lubbock Public Health Department through our regional office and our central office here. We're actively monitoring the spread of the disease and preparing for potential future outbreak scenarios. And we're doing these plans in coordination with public health partners, like our local public health partners out there, as well as the Texas Division of Emergency Management. If you flip over to the next slide, it shows a map. And so this is the confirmed case count that we announced on Friday, and the counties of residence for those confirmed cases. Over on the left-hand side of that slide, you can see that we've shaded the counties where those folks come from. You can see that outbreak is happening. It's really centered around Gaines County and those surrounding counties, but we've also identified cases in other counties in that South Plains and Panhandle region. We currently, over the weekend, have had more confirmed cases, and so our case count is now at 158 rather than 146. The same 9 counties are still involved, though. That has not changed. If you go to the next slide, this shows the measles cases by age group. And what you can see is that highest bar there falls in that 5 to 17-year-old age range. And so most of the cases, I should say, of all the age groups, the most have been found in that 5 to 17-year-old age range. At first, it was most of our cases were in this 5 to 17-year-old age range. Since then, we've seen it moving into younger age groups. And so we're now having increases in that 1 to 4 year age group, as well as that infant age group of less than the age of 1. If you go to the next slide, this is just a breakdown of this particular outbreak, the hospitalizations that have been associated with it. So on the far left, it shows the age group, and you can see it's broken down into those, the infants, 0 to 6 months and 7 to 11 months, and then the 1 to 4 year olds, the 5 to 17 year olds, which is that school age range, and then older individuals or adults. And you can see the cases broken down by those that have been hospitalized, those who had needed admission to the intensive care unit, and those who sought care only in the emergency department and did not require admission. But what you can see is that there have been people going to the hospital that have had severe enough disease to go to the hospital, be admitted into the ICU, and most of this is occurring in Lubbock. If you go to the following slide, this shows our 2025 Texas Measles Outbreak response activities. And so I'll go through some of the activities that we have initiated and continue to support. So in that first group, it shows measles specimen collection sites. We know that getting specimen collection and getting those specimens to a lab is really important. We do a lot of the testing here at our public health lab in Austin. We want to make sure that that happens quickly. And so we have set up 7-day-a-week specimen collection sites and 2 sites in this outbreak area. We also have 4 strike teams that can collect specimens. They can go out and collect specimens if that's more convenient for where we're noticing cases or suspect cases. For laboratory capacity, as I mentioned, most of those tests had been coming to our DSHS public health lab here in Austin, and we have a fairly quick turnaround. There is commercial labs that can do it. They just have a longer turnaround, and so we've been trying to direct a lot of them here. Because this outbreak is happening out in South Plains and the Panhandle, we have asked our laboratory response network partner, and so it's Texas Tech, who runs a public health lab out there, asked them to also stand up testing and have given them all the support and supplies that they need to do that. They should be standing that up this week for local testing to be done. We're also working with El Paso, Tarrant County, and Bexar County to bring up measles testing in their public health labs to make sure that we have got capacity all across the state to do this testing quickly. We've also increased our own capacity at our lab here in Austin to make sure that we can run them quickly when we do get specimens. On the next slide, you can see the title, Access to Vaccine for Individuals Who Want Them. So we know that this vaccine, MMR, is highly effective at preventing measles. After the first dose, it's about 93% effective. After the second dose, it's about 97% effective. And because of the effectiveness of that vaccine, the United States was able to declare measles eliminated in the year 2000. And so this vaccine, like I said, has a long track record as well. We've used it for over 50 years. And so we know that this is a primary component of outbreak control and preventing outbreaks across Texas. And so we have stood up vaccine clinics that are operating 7 days a week in sites there in the outbreak area. We've also been accessing vaccine resources from CDC in order to push out through our existing vaccine programs, so Adult Safety Net and Texas Vaccines for Children. We have specific outbreak vaccines that we can use in this outbreak area for people who don't fall in, vaccine providers who don't fall into one of those networks. In addition, we've purchased other vaccines for other circumstances. We just want to have vaccine available for whichever providers can give those vaccines, especially in that outbreak community. But now we have communities that have experienced exposure of these vaccine cases as well. Of these measles cases as well, and we want to make sure that we've got vaccine available when they need those anywhere across Texas. And so we do have 5 deployable vaccine strike teams that can also go outside of the clinics that we've established and get vaccines to places where they need it. Under that, there's access to post-exposure protection to prevent illness. And so if somebody gets exposed to measles, there's a couple of ways that we can try to prevent it. And so we can try to get them a vaccine within the first 72 hours. And that can sometimes prevent disease in them. If it doesn't prevent it, it can at least make it more mild. And so we try to get vaccine out as fast as possible if somebody's been exposed. If we don't hit that 72-hour window, occasionally, we can also give immunoglobulin injections. And so this would be particularly for those babies who are under the age of 1 that are really susceptible to health complications. And so we are making sure that we have purchased more of this immunoglobulin and that we have positioned it out in the South Plains region so that we can prevent those really vulnerable Texans from getting sick. If you go to the next page, it talks about surge staffing to assist with specimen collection, epidemiology, and vaccination. So we have deployed a lot of our DSHS staff. So we've sent staff out to this outbreak area from our central office, as well as our other regional offices across the state that aren't experiencing this type of outbreak, and made sure that our partners out in the South Plains region have resources. So our DSHS employees have been doing that. We also have 27 contractors that are beginning today there in this outbreak area to assist local public health departments. We've also requested resources from CDC, including physicians and epidemiologists, to help with case investigations and hospital exposures there in the South Plains region and in Lubbock. Furthermore, we are doing messaging to ensure that individuals know that there's a measles outbreak going on and that we've got vaccines available. And so we've done public awareness efforts to cover the Panhandle and South Plains region. That initial education will include billboards and social media messaging, and that has started this week. CDC has been supporting us in that as well. And DSHS can expand education efforts to other regions across the state as well if it becomes necessary. On the next slide, I talk about awareness and education for providers, schools, and local health departments. So we have issued health alerts to ensure that providers are aware of this outbreak. We're holding regular webinars through Texas Medical Association and Texas Pediatric Society. We're working with the Texas Hospital Association and Torch for those rural hospitals to make sure that people know what's going on and know that they can call on us if they have any questions or need any help. We're also working with school districts and local health departments. We're helping with hospital planning. We have done a call to hospitals across the state looking at their pediatric bed availability. We're starting hospital reporting this week using a platform called EM Resource, and so that we can look at those pediatric resources from across the state, including pediatric ICU beds, to make sure that we are prepared to take those patients if Lubbock becomes overwhelmed, that we know where we can transfer patients for that higher level care. And then we are, on that last slide, coordinating with appropriate state and federal agencies. So we've been working closely with Texas Division of Emergency Management, had multiple phone calls with Mike Morath of the Texas Education Association, and so working with TEA and TDEM. We have also been working with CDC and federal HHS and to see how they can best support us in these response efforts. If you go to the final slide in that packet, it shows kind of what our expectations are for this outbreak. So due to the number of suspect cases that we have right now, we do expect more confirmed cases to occur in this outbreak. We know of other outbreaks that have happened in the last 10 years across the United States have lasted months, some of them as short as like 2.5 months, but like the one in New York lasting about 10.5 months. And so that this could go on for a while until we are able to fully contain it. Some of the other expectations is that children who test positive for measles, as well as those who aren't vaccinated and get exposed to measles, are excluded from school due to the contagiousness of that disease. And so we are trying to work with TEA to try to minimize learning loss that happens there and loss of school funding. And then we are concerned about our MMR coverage across our state, knowing that it's lower than some other places across the United States, and that this particular region has lower vaccination rates, but that there's some areas in Texas that have very high vaccination rates, high enough to protect their communities. And so really watching that, but knowing we need to really be on the offense of offering those vaccines and getting education out so that parents can make those decisions to protect their family and their kids. And that concludes my presentation about measles, but I am happy to answer any other questions that y'all have.
Okay, thank you. Members, questions? Representative Busey.
Thank you, Mr. Chairman. Commissioner, thank you so much for your report, and it seems like your diligent work to try to contain this. This is the biggest outbreak in Texas in over 30 years, isn't that correct?
Correct.
Can you talk about why that would be happening now? What's going on, especially if we've eliminated this disease in 2000?
So the continuation of elimination of measles depends on having a certain level of immunity in a community. And so we've been getting that through vaccine. Usually at about 95%, we have what's called herd immunity. And so like if one person brings in a case of measles to a community, there's just so much protection there that it can't cause an outbreak. But we know when those vaccine levels get lower than 95%, that there's enough unprotected people together to cause an outbreak or to allow an outbreak to happen. And so this was merely an introduction of measles into an area where there are pockets of lower coverage of that measles protection.
What's the trend? I mean, if this hasn't happened for 30 years like this in Texas, are we no longer vaccinating Texans? Is that what's going on?
As I mentioned, there's some communities across Texas that are highly vaccinated, above that 95% threshold. Here, there have been, in this region, some decreasing vaccine coverage rates in recent years.
Is that because we don't have enough vaccines, or what's going on that's causing that trend?
No, we have plenty of vaccines and make them widely available through our different vaccine programs so that people who have insurance coverage and those who don't or are underinsured have access to vaccines. And so we're making sure that happens. But there has been just some decreased interest or distrust in vaccines, and that's caused a decrease in vaccination rates.
And okay, so let me ask you this. If people don't get vaccinated, they're not just putting their own health at risk for this? What are they impacting their community? Can you talk about how that impacts how one person choosing not to get vaccinated can impact their neighbor?
Sure. So we know that for the most part, when people get vaccinated with one dose, it's 93% effective, and when at that second dose, it's 97% effective. But we also know there's people within a population who don't have a great immune response to vaccines, and so they're not going to get that full protection. We know there's pregnant women whose immune response goes down a little bit during pregnancy and can't be fully protected. And those babies who are less than one that don't usually get vaccinated. And so there's vulnerable people within a population that can become infected if the other people within the population don't get vaccinated.
So just to understand, if someone chooses not to get the vaccine, not because of health reasons, but they choose not to get it living in a denser population or community, They're not just impacting their own safety, they could be impacting the safety of their neighbors and their community, is that correct?
They're allowing it to be able to spread to other people.
What do you need from us as the legislature? What can we do? Not just policy, but what do you need from your elected leaders to help stop this?
So we are going to continue to do what we're doing, including messaging, but we are actively trying to get local health departments and local healthcare providers and local leaders to help with some of this messaging to their communities. They know their communities way better than I know their communities sitting here in Austin. And so looking for people to be good messengers to their communities and help us get this communication out about the importance of vaccines.
Is the MMR vaccine safe for people to take?
So we know that anything that goes into your body, any pharmaceuticals, can have side effects, and that includes the MMR. We know that some people are allergic to MMR, but we also have 50 years of track record on this vaccine showing that the benefits outweigh the risks on this one, and that the risk of measles right now is pretty severe. We already have a child that's died. We've got over 20 people who have been hospitalized just within this outbreak. And so the risks of getting measles are real, and this is a vaccine that we've had for years where we know the benefits of this one.
So you need us to help speak up to our constituents about why they need to get this to help.
I think that would help us contain this outbreak.
Can you real quickly speak to what the case that just happened here in Austin in Central Texas? And is it a standalone case or what's going on there?
It's a standalone case associated with travel, and that also happened in Rockwall County, I believe. And so there's been a couple of these, and those two that I mentioned from Harris County, where they were travel related. They came back, but they didn't contact other people who were unprotected or unvaccinated, and so that outbreak didn't spread, or it didn't cause an outbreak. Those cases didn't spread further, where what we're seeing out in the South Plains region is that is within this pocket of unvaccinated people, and it is spreading.
Well, thank you so much for all of your efforts. And Mr. Chairman, thank you. I hope this committee can help lead in the awareness campaign around this. Thank you.
Thank you. Representative Simmons.
Well, thank you, Rep. Busey, for asking all of the questions that I needed answers to, so I appreciate that. So I'm good. Thank you, Mr. Chairman.
Okay. Representative Frank.
Thank you, Chairman. Just a couple quick questions. Of the folks that have been confirmed with measles, were any of them vaccinated?
Yes, some of them were vaccinated, and that happens. Not everybody who's vaccinated will get that full response. We know that some of their immune systems don't respond as well. We also know that some of those got vaccinated very recently, and it could have been during this response time where they got it as post-exposure prophylaxis. So we're still trying to separate all of those out.
Okay, thank you. Because I'm trying to, and I want to be careful the way I ask this, because I think the measles vaccine is, proven and something we need to push and or encourage, maybe is a better way to say it. It seems to me we have the most recommended vaccines of any country in the world, pretty much by far. And there's a bunch of reasons for that. Some of them good, some of them not, in my opinion. It seems like some of them are truly vaccines, truly keep you from getting something. Right? And then some of them are almost like pre-treatments that we're pushing as vaccines. Am I wrong on that? And I probably should have asked this offline. We're just, but hey, I'm going to ask. Because I think some of it, the distrust is caused, I think, in some parts, rightly or wrongly, by perceived information or sometimes actual misinformation coming from people in authority. And so I'm trying to figure out, like the measles vaccine seems a very clear case, something we should do. And then yet there's other things that are called vaccines that sometimes I don't think operate like vaccines, don't keep you from getting it, don't, so.
Yeah, vaccines are really complicated.
Well, I feel like we need different words for the
ones.
different vaccines.
Yeah.
Like some vaccines are really vaccines, really keep you from it. And then some are not quite as much like
So
that.
this
May still be
particular-
necessary, but.
This particular vaccine is a live virus vaccine. It's a weakened form of the virus, and it causes a really strong immune response that can last for the rest of your life. And so it's one of our really good ones, where things like the flu vaccine or the COVID vaccine don't provide that same level of protection. A lot of what you get there is just a less severe illness when you get infected, and so, there's different perspectives or goals of these vaccines for sure.
Well, I think it's funny, you said something very interesting. This is one of our really good vaccines. but yet we use the same word for all of them, and then we wonder why we're confusing people. And because there is a significant difference between like this that clearly needs to be done in the vast, vast, vast majority of the cases, and others that maybe it's just better, worse, personal choice. Am I off base on that?
I think there's different, the risk-benefit ratio on these are different. And so you're right, like some of them are much more clear. But I think that's how those recommendations are formed. It's just if the benefit outweighs the risk. But there's this huge spectrum, right? And I think that's
But I
what
think
you're
this is
getting
where
at.
the subtlety is lost on most people,
Yeah.
because it's either you're either for every vaccine or you're an anti-vaxxer, and I don't think that's where most people in the world are actually residing, or maybe there are too many that reside there. But I think there's things that go on the risk spectrum, and clearly the measles in this particular issue is one where we have the history, we know the science behind this, but it's hard for people to understand the difference when we're calling it all the same thing,
Yeah.
in my opinion.
And we will be working on communication of all of these as well. So thank you.
Thank you. Representative Johnson.
Thank you, Chairman. And Chairman Franks, thank you for those highlight on the efficacy of the measles vaccine. There were a couple things that I thought were missing in the presentation, and no criticism, but I want to make sure as we're having this discussion about public awareness that people are really clear about what we're talking about in MMR, measles, mumps, and rubella. So measles, because you've got all the symptoms and everything that can happen here, you also highlighted the fact vaccine is the best way to prevent. But I want to talk about when people get sick. There's no treatment at that point, correct?
There's
You
some
can get
data-
vitamin A and be put in the hospital,
Yes.
but there's no give me the pill now once your
no-
child is sick.
Yeah, I'm sorry to interrupt. Yes, there's no antiviral that's specific for measles. There's supportive care, including some data behind vitamin A, but that's after you get sick. It's not preventing it, it's after you're already ill.
And so that's why we're seeing children who can die, that this idea that I'll just let my kid get it, they'll build up immunity, it will be fine. You said 20% of these kids are ending up in the hospital.
Correct.
And in fact, when we look back statistically with where we were in measles, back in the United States, when we started tracking it back in the 1950s, and then into the 60s, we were looking at, like we saw in COVID, multiple spikes up and down, and we were getting 700,000 cases, correct, at a time.
Every person was getting infected by adulthood, basically, almost every individual living in the United States.
And then vaccines were licensed in 1963, and over the next decade, we saw that drop significantly, almost to nothing. And as you said, in 1971, we all got one shot. And that's, I've heard 90%, I heard you today say 93% effective, correct? And so for folks like me, who were a child in the 70s and early 80s and got my vaccine, I've actually only had one. And so there is an argument that some folks may need to get a boost and get that second dose, correct?
That's correct, especially in these areas where there is an active outbreak going on.
Because that 6% of efficacy can make a big difference in healthcare, especially when we talk about herd immunity, correct? For those that are after 1989, they got 2 doses.
Exactly.
And the nice thing about measles is once you get that treatment, you're really done, except for those very few 3% cases that may
Yes.
contract it and get it. And so the nice thing, again, about a measles is in 2000, we started to eliminate this disease, and it hasn't really changed. It's one of those that's pretty stable and secure, and we know what happens, right?
Yes.
So in 2004, in 3 and 4, in Texas, we saw 2,314 religious exemptions as reasons not to get the vaccine. To date, that number has continually climbed to now that we have 118,572 people claiming religious exemptions for purposes of not getting a vaccine. Do you think that those are purely religious, or do you think that misinformation and disinformation and causes, illogical causes around the lack of understanding of science can cause to the contributing factor for people claiming to need an exemption?
So it can be for a reason of conscience, but I don't know any specifics beyond that, just that we get that exemption. Or information about that exemption from the school districts.
And as you said, if it gets to 5%, we lose herd immunity in the entire county, right? And these dark blue sections are showing almost 35 counties at least that are getting close to that tipping point in the state of Texas. Is that your awareness?
Yes.
All right. I want to talk about some of the disinformation and misinformation, and not that people, I get it, people are worried and they're concerned. We've heard people say MMR can cause autism, and I think you said it's safe, we recognize it's safe. So there is a distinction for folks that have an anecdotal story of, hey, I got my baby vaccinated between 7 months and a year, and then my baby started showing symptoms or signs of things like autism or other genetic diseases that don't present themselves until about that time in fetal or infant development, correct?
Yes, so studies that have been performed looking at any link between those have found no link between autism and MMR or any other vaccine.
Thank you. And so, as a leader in the state of Texas, you are letting people know the rhetoric around autism and MMR is not accurate. Mm-hmm. This is a safe vaccine. We know about measles. We know that measles can cause high fever and brain damage. We know that kids can die. I want to talk about mumps. Mumps equally, 20% of boys that get it will get such swollen testicles they'll get infertile. Correct?
I don't know the exact
All right.
statistic, but absolutely that is a complication of mumps.
So if you don't get your little boy vaccinated for MMR, roughly 20% of them may not carry on the family genetics, right?
Yes.
Let's talk about rubella. Rubella, if a woman gets rubella, 70% of them are going to get arthritis, right? And if a pregnant woman gets rubella, there's significant risk of blindness and death, intellectual disabilities, liver and spleen damage to their child.
Correct. Congenital rubella syndrome, yes.
So that's the real implication of us as a state of Texas not paying attention to the public health necessity that we all do our part to get our kids vaccinated, because it's really our kids that are suffering. It's not much of a choice for that kid, right? And so another disease that has been almost eliminated is polio. We also see vaccine hesitancy that carries out not just for MMR, but can affect polio.
Correct.
And we now have an outbreak of polio in New York.
There have definitely been cases in New York, and they have identified it in the wastewater there. So it appears that more than just one person has it there, yes.
And so the time to talk about the efficacy of vaccination, to calm people's fears, to not use illogical rhetoric, but to let people know this really can become an even bigger public health crisis. And what we're talking about today needs to be taken seriously. And I'm so grateful that you're willing to come in and talk about that.
Absolutely.
Thank you,
anytime.
Doctor.
Thank you, Chairman.
Thank you, Representative Pearson.
Thank you, Ms. Schufert, for your update. Just wanted to sort of expand a little bit on what Representative Frank said with regards to the communications and what we are talking about versus what we're not talking about. And I just wanted to go back to something you said about MMR being safe and used for over 50 years now. And my point is really one about clarity. Are you saying that the MMR vaccine is the same today as it was 50 years ago?
Yes, there is one formulation that's the same as it was all that time ago. There have been two other formulations since then that they're all part of this, though, live attenuated virus vaccine that is very similar to the one that was done over 50 years ago.
But they're not the same. They're different today than they were 50 years ago, just different variations.
One of them is the same, and then two additional ones aren't quite the same.
But when we're saying MMR,
Yeah.
we're speaking of them broadly to include all of them.
Yes, that
Okay.
is true. Yep,
Okay.
you were correct about that.
And then are we tracking the efficacy over time of the different variations of MMR?
Yes, we continue to follow the effectiveness of those vaccines over time.
And they're generally the same.
Yes.
And so would you mind providing that to the committee? So that when we are looking at the effects of MMR and efficacy,
Yes.
what we're actually looking at?
Absolutely.
Because Representative Frank actually told us that some of these people were vaccinated that actually came out with
Yes.
the with the disease. So I'm just curious. Well, yeah, you let us know after the question.
I did say that, yes.
And I think
correct.
that's very important because getting vaccinated, if we're using the term vaccine, doesn't necessarily mean you're not going to contract the disease. Is that correct?
That's correct.
Okay, so I think it'd be helpful if we could look at that data.
Sure.
Thank you.
Just to clarify, I think she said it's 97% effective. So the data she presented was it's 3%.
Correct.
Okay.
But I'd like to see the data. That's okay. Thank you.
Thank you, members. Representative Jones?
Can you hear me? I actually want to take a point of personal privilege before I ask you some questions. I see my predecessor, Chairman Garnet Coleman, sitting back there, so I'd like to recognize him. In any case, question for you. For people who have small children,
Yes.
like I happen to have a granddaughter who's 1. I literally have been texting my son and my daughter-in-law saying, hey, has she been vaccinated? There's a measles outbreak, so I'm concerned, right? So I know that there are other people like me. Can you tell me when babies start getting vaccinations? Because I think my daughter-in-law says, oh, we're following, I guess, the CDC schedule. So when do babies get vaccinated for measles?
So the first recommended dose comes at 12 to 15 months, so right around their first birthday. And then the second dose is between 4 and 6 years, so about the time that they're going into kindergarten.
Okay, that was helpful to me. For people who don't have health insurance, are measles vaccines free?
Yes.
If so, where do they get them? Do they go to the city health department? Do they go to the county health department? Can they go to some other health department? Explain that to me for people who may not have health insurance.
Sure. So we have a program called Texas Vaccines for Children, where we give vaccines. CDC provides them. We push them out across Texas to TVFC providers. Some of those
TVFC.
Texas Vaccines for Children.
Okay.
Providers. And so definitely our local health departments and our state health department offices, but also just pediatricians, family practitioners, other people who are providing care for kids can be providers of Texas Vaccines for Children. And this program also feeds in and provides vaccines for the Medicaid kids. So overall, this program provides vaccines for about 4.5 million kids every year.
Well, so in Texas, we need to expand Medicaid. That's my little plug for that. So I'm concerned about people because I've been uninsured before, and I don't even feel like telling you the nightmare of not being insured. But for the people who are not insured, I want to be able to tell them where they can go.
They can call their local health department, and if they don't have a local health department, they can also call our regional offices. Whether they do or don't have a local health department, they can call one of our regional offices, and we can get them to a place.
Thank you. I appreciate you.
Yeah, absolutely. Thank you.
Thank you. Representative Alcott?
Dr. Schubert. So earlier you mentioned that the measles had been essentially eliminated in 2000. Have you all considered the possibility that because of the enormous surge in foreign nationals coming into this country recently, many of whom, maybe even most of whom are not vaccinated, that could have been the source of the outbreak? Obviously, there were some people there that maybe in the community that didn't believe in vaccination, didn't get vaccination, but I'm just curious as to the point of where maybe this was initiated, where it came from.
So many times with these these outbreaks, we can identify exactly how it was brought in. And a lot of times it's just international travel that we see. For this particular outbreak, we don't know the individual who introduced it into the community or what the risk factor was for bringing it in. We know that measles is alive and well in other parts of the world, and so all it takes is one traveler to bring it in.
One other follow-up question is, do you happen to know whether mercury is contained in the current form of MMR vaccine?
It's been taken out of the MMR.
Okay.
Representative Frank?
Thank you, Chairman. Do you know currently CDC recommendations, how many separate doses is recommended for a child by the time they're 18 in this country, and how that compares to other countries?
So I've heard people say it's 72. I have not counted them
I
myself.
think it's 86.
It might be.
If my
Okay.
plot is correct. But it's significantly higher than any other country and quite a bit higher than, and I'm talking first world countries, right? I wondered, would it make sense, and this may be putting you on the spot, you mentioned really good vaccine, really important vaccine, and some are different on the risk spectrum. If we're going to go science, and that's certainly your role, should we tell people where things are on the risk spectrum so that we can tell somebody, hey, this is very low risk, high reward, and we go down the road to the one that's the furthest out there, the one that you wouldn't call as good? Because it would seem like that would be much better information for somebody than just vaccine. And anybody who questions the efficacy or where it is on the risk spectrum is considered, crazy and an anti-vaxxer, which is not the case. But we actually deal in real science and not just lump everything into this group of vaccines that you yourself, as a scientist, is saying, hey, this one's good and much better, this one has a different risk spectrum. So is that not information that maybe we could provide to people to say where these vaccines are on the risk spectrum?
So can I back up for just a second
Please.
with the 86
Sure.
or 80? That those are components, and so the MMR would be 3, and
But they
DTaP.
are literally separate components, all
I-
with the
I
ability to
agree.
interact, right?
Yeah,
So
I just don't want
put
people to think that
just
we're
because you
giving
put
80.
5 in a shot doesn't mean that you still have different
Yeah,
reactions,
you
right?
absolutely have
So they are
those different
they are
ones.
individual doses, but you are correct. It's
Yeah.
not 86 shots, but it's
Yeah.
86 separate doses during an 18-year-old, just the first 18 years.
Yes.
And I'm not saying that's too much. I'm just
Yeah.
saying you yourself say there's a different risk reward on the spectrum, and yet we don't do anything other than tell people you need to get the vaccine. And oh, by the way, the pharmaceutical company has no liability because we have waived that. So they are at zero risk, although they are at tremendous benefit of encouraging these, right? It's unbelievable. It's a great business model, right? I get to manufacture it, you require it, and then I have no risk. That's a pretty impressive thing. And then we lump all of these into something called vaccines, even though you yourself say there's a tremendous difference in the good versus risk, right?
Risk-benefit ratio.
And so it would seem like if we're doing our job as scientists and leaders, we should be able to say, hey, here's where this is on the spectrum, and we should understand that maybe different people have different risk rewards, maybe some people have different reactions, immunizations, not immunization, I'm using the wrong words, but could we do that? Would that make any sense? I think.
Yeah, I think that it does make sense, and that we're considering ways of communicating about vaccines, because clearly there's so many questions around it, and rightfully so, and that part of it's on us in public health not being able to communicate well about it. What we have typically done is taken the CDC recommended vaccine schedule, and because they're doing that risk-benefit analysis, looking at all of the data surrounding the risks and benefits, and then saying that the benefits outweigh the risks here, and so we're going to recommend it on this schedule. And so adopting that with them doing that analysis. But you're right that there's a lot of thoughtfulness going on from individuals who are getting it, and that we need to adapt our communication.
Well, it
plan
seems
around
like
that.
as we do on a lot of things, we're falling into the take everyone or you're an anti-vaxxer or you shouldn't take any at all no matter what. And that's not, I don't think, even great information.
Right.
I think we can do better as a state, and I'd encourage you to look at it if you don't want.
Representative Collier.
Thank you, Mr. Chairman. This has been so enlightening. I just appreciate all the questions. They're very helpful. One question that I have, you talked about the 21-day quarantine in public school, or in schools, period, I guess, public and private. Is that true?
Yes.
Does it apply to private schools?
It's the Texas Administrative Code says that the school administrator shall exclude, and then it gives the list of different infections and exposures that require exclusion.
Okay. So then the question that I have is, when is someone considered to be exposed to measles?
Yeah.
And like, if somebody, they don't, but if somebody here had it, am I exposed now, even though I haven't been within ear reach of, face-to-face with them?
Yes, because of the way that measles is spread as an airborne pathogen, we talk about an airspace, and so this room would be considered an airspace.
So can you please explain when someone is exposed?
Mm-hmm.
Can you tell us exactly, like, being in a room that is, 300 square feet, you would be considered exposed? I just want clarity.
Yeah, and so a room that is, this would be an airspace. We would consider, because you walk through the room, the air sits in the room, we would consider this an airspace. Any, like hallways in schools with kids walking up and down it, they expose basically everybody. Cafeterias, gymnasiums, people are moving within one enclosed space, and so we would call that an airspace, and that there is infectious virus in that airspace, and therefore that equals exposure.
Okay, because if the school is to quarantine or ask this family to quarantine the student for 21 days, what are the schools you looking at? Are they saying anyone that attends the school that is unvaccinated must be quarantined? Are they doing it that way? I'm just trying to figure out for some guidance for these schools.
And so it would only be those that are unvaccinated, under-vaccinated, the ones that aren't fully up to date on their MMR vaccine would be the ones that would potentially be excluded. And then, anyone who's sharing common spaces or in classrooms with an infected person. The way that we can break that chain is either if we can get them vaccinated within 72 hours of exposure, which is hard to do sometimes, or after that time of exclusion, getting them vaccinated and getting them back to school, and so that they don't have to be excluded again.
But does the school have to exclude them? I thought the quarantine was kind of like voluntary. Like, I agree to quarantine my child.
Yeah. The Texas Administrative Code says that the school administrator shall exclude an exposed child who's not up to date on that vaccination.
Okay. So then I suppose if it's a school, then what about childcare facilities? How does that work?
There are guidance. There is TAC around childcare facilities too. I just can't quote it off the top of my head, but I can give it to you. But those are covered as well.
All right. So are we getting guidance, and are we looking at the data to where those individuals were, if they went to a child care facility, or if their sibling was at a child care facility? Are we tracking all that?
Yes, we are. We're doing case investigations, so anybody that gets infected, asking them where they were to try to find out those areas of exposure so that we can let those potentially exposed areas and parents know that to be looking for this, and then we capture that information, say if somebody gets infected and we start doing a case investigation on them, that they were exposed to this place. And so we are trying to maintain all of that information to see how that's spreading.
Okay.
We also have worked with the school districts on this, and we've had lots of phone calls and emails with Seminole School District and other school districts out in that South Plains region. I flew out there, I guess it was exactly 2 weeks ago, and met one-on-one with the school ISDs to walk them through this, but also to tell them, we are open to questions. We know questions are going to come up, because there's so many nuances to it, and that we can continue to work through those questions as we move through this outbreak.
Sure. So we know how many students are unvaccinated because they have to file that affidavit, right?
Yes.
Or the form. So for the schools, you said that you're going to work with them on attendance because the schools are paid on daily attendance.
Yes.
What about the child care facilities that are part of I think it's the RISE program? Like, you cannot miss so many days before the child care provider is not paid for their work. Are you doing something similar to ensure that they also don't lose money?
I don't know the answer to your question.
Okay.
But I can get back to you on that.
Okay, 'cause I'd like for you to look into that,
Yeah.
because if you said that the child care facility also would be subjected to quarantine provisions, the quarantine provisions, then they too could lose money. But you want them to be safe and practice the recommendations or implement the recommendations from the state that are proven to be effective. So thank you so much. Those are my questions.
Representative Schaffner.
Thank you, Mr. Chairman. Thank you, Dr. Shuford. Of the total cases today, you said it's about 146. Is that correct?
It's a little bit higher as of today. It's 158.
158, excuse
Yes.
me. All right. And then at what number, how do you calculate what number, what percentage that you consider it to be an outbreak?
So
When do you
there's-
use that phrase?
Sure. When there's 3 cases that are related to each other. And so if it's just one, just a traveler who
Right.
came back or something, but if it spreads and there's a cluster of 3 of them, then we start to consider that an outbreak.
Okay, so 3 cases, same family, same neighborhood, whatever it is, would be, you would use the word or term outbreak.
Correct.
Okay. And of that child, there's 1 child that has died so far, is that correct?
Correct.
And did that child, what was that situation? Did it have other comorbidities or
Yeah.
what happened?
And so the information that we know is that it was a school-age child that was unvaccinated and don't have information about all of those other aspects of that case right now.
Okay. And of the, you had mentioned that this is international travel, you suspect is the reason why that this happened. What countries did they travel from?
So for this particular case or this outbreak, we don't know who introduced measles into the community and from what country. We just don't know that about this particular
Do you
one.
have a guess?
I don't about this one.
What
There's-
other country nearby might have an outbreak of measles or the possibility of?
A lot of the travel that we see over the last few years have been from European countries. They've been from the continent of Africa. We know that some travelers from Africa were linked to cases that we saw in our state earlier this year. And so a lot of the cases are from those sources.
Okay,
I just can't tell you about this one in particular.
great. And for instance, the flu, would you consider the flu as of today an outbreak? Flu, A or B?
Yeah,
I'm sure
it's-
half the people in the room have had the flu already.
So we typically say that there's epidemics of flu every year,
Sure.
seasonal epidemics.
Right.
Yes.
And is there some sort of number pertaining to the flu outbreak?
Sure. We usually say that when it exceeds what we would normally expect, kind of a year-round baseline, that's when we call it an epidemic. And during flu season, we have an epidemic of influenza every year.
Sure. And what number is that, for instance, for Texas in general?
Gosh, it's like 3.8% of provider visits with clinical flu. There's a baseline, and it changes a little bit from year to year, but it's
Sure.
when it goes above that we call
Okay,
it that.
great. And you had said vitamin A, how supportive is that in someone who has contracted measles in helping the symptoms?
Most of the data from vitamin A supplementation to help with measles is from Africa, where there's a lot more vitamin A deficiency than what's in our country. And so it's hard to know. I know they're trying to set up studies right now to try to determine how helpful it is. But we know from other countries that it does decrease mortality in people with severe measles, which is why it's part of treatment recommendations.
Great, thank you so much. Thank you, Chair.
Okay. Vice Chair Campos.
I have a question. So can you tell me how many unvaccinated exposed children have actually been out of school? Do you have a number?
I don't have that
Because
number.
there's 146 cases in Texas, so that just seems like a lot, and it's very concerning to know that unvaccinated, kids are not attending school. So you don't
I do not know that number, and I don't know that the school district has submitted that to us. I don't think it's a requirement, and so, but we can try to find that out for you.
Okay, that'd be great. Thank you.
TEA might have that information, but we can check on it.
Thank you.
Okay. Representative Simmons.
Thank you, Mr. Chairman, and thank you so much for joining us today. So, just had a quick question. Would love for you if you could talk to us through about some prevention. I know when COVID, when we're still in a pandemic, so I don't want to say we're out of it, but kind of right at the beginning of that, we were told to mask, and I know personally for us, we saw that it was pretty effective. My daughter has sickle cell disease, and that was the I want to say the time of her life where she spent the least amount of time in the hospital because we were just not transmitting different things to her. So would masking in this case be effective in reducing transmissions of measles, or are there other methods that we can think about to really reduce that risk now that we are kind of in a full-blown wave of this thing going around the state?
I don't know if data of a person wearing a mask to prevent spread of measles elsewhere. I know that, say, in a hospital environment for infection control, nurses or physicians that will go into a room with a measles patient will wear an N95 mask because it's an airborne transmission disease.
And really quick, because I stepped out for a bit, so you may have covered this, but kind of what threshold of benefit to risk ratio does the CDC use to determine whether to recommend a vaccine on its schedule of recommendations? I know it's maybe different for folks who are chronically ill and may have some, skepticism around the schedule that's currently out, but can you just talk a little bit more about that?
Yeah, I just know that I don't know of particular thresholds. I know that they do analyses where they look at benefit to the individual, benefit to a community, and then look at costs as well, about the complications and hospitalizations that occur. But I can't tell you exactly what that formula is. It just happens with these vaccines.
And just thank you for that. And I guess finally, I know that we've talked about it in different ways, just the hesitancy around vaccines and the schedules. And I know that there, have been reports from doctors who have, people that are doctors, and they say, well, I'm a doctor and I'm telling you that, vaccines are bad or good or whatever. Can you kind of talk about the difference between like a doctor, immunologist, and people who have the expertise to kind of ensure the effectiveness of vaccines and kind of what that process looks like? I know it's probably more detailed than you have time, but for just a layman like me, could you just walk us through how do we realize that vaccines are safe? How do we know their effectiveness? And who has kind of the designation and the expertise and experience to actually tell us whether a vaccine is safe or not?
And so some of that happens with the FDA during approval process, where they submit data looking at effectiveness, but also the safety profile of a particular vaccine. It's true for medications as well. But after that becomes approved, and there's a number of vaccinologists and things that help develop vaccines, but then once that get approved, it goes to ACIP, the Advisory Committee on Immunization Practices, which is a committee at CDC who does the evaluation of the data, and they include immunologists and physicians on that committee to read all of the available research around it, determine those kind of risk-benefit, do the risk-benefit analyses, and then determine whether they want to recommend it and on what schedule.
Thank you, and I just wanted to get clarification on that, because I've even had people tell me, well, this doctor, put this report out, and I'm like, yeah, but that person is, and not to say a chiropractor is not a real doctor, but that person probably is not the expert on, viruses and immunity. So thank you so much for that.
Yeah.
Representative Jones.
Number of questions. When you get, so there was some questions earlier about it's not 100% effective, 97%. My question is, back when there was COVID, well, there's still COVID, but back when COVID was, we didn't know what would happen and people were dying like flies. If you're vaccinated, does that help mitigate the consequences of getting, say, COVID or measles? That's my first question.
So frequently a vaccine does, and that's the aim of some vaccines. And on the MMR vaccine, we would expect that the measles, on average, measles would be less severe for somebody who has been vaccinated.
The next question, based on some questions that my colleague Collier asked, are parents told how many students at any particular school are vaccinated or not? Especially now that we hear, or now that I've heard this morning, that 95% gets the herd immunity. as a parent, I'd like to know when I'm sending my child to a school, how many of the kids are vaccinated?
So every year, the school will submit to DSHS the number of exemptions that have been filed for the kids at the school district. So we have it at the school district level, and that's posted on our website for people to see.
So it's at the school district level, it's not at the classroom level?
That is correct.
Okay. You didn't say anything about international travel, linking it to anything. I just want to make sure I heard what I heard. You didn't hear anything about, you just saying some people were trying to get you or asking you questions if you can link it to international travel. You didn't bring that up.
I cannot link this particular outbreak. I don't know. Usually we can find that link, and so it's driving me crazy, but we don't know what the link is here.
Because my concern is when you start speculating about countries and people, that implicit bias can kick in. And in science, we want like peer review that you can document. Would you agree with me?
Yes, I'd like to be able to
Right.
document
So
it.
you didn't say, because you mentioned Europe and Africa, about some, I don't know, some outbreak that happened somewhere else that's not related to measles. You just brought up in Europe and Africa, which bothers me because I'm of African descent.
Yeah.
Right.
It's happening in Israel too. It's kind of
All right,
all over
okay,
the
that's
world.
all I'm trying to say.
Yeah.
Yes, ma'am.
It's certainly not one place in particular.
Right.
We're seeing outbreaks all over
So
the
none
world.
of the cases here in Texas, can you scientifically link it to international travel? Is that accurate?
We can for other cases that have happened over the last
I'm not
year,
talking about that. I'm
but
talking about, hold on.
not this outbreak.
Just hold on.
Yeah.
I want to be clear. I don't want you to bring in anything else. I'm worried
Sure.
about this measles outbreak right now
Yeah.
in Texas.
I can't
thank you very
associate
much.
this with any
Okay.
international travel.
All right. And then you talked about some vitamin A deficiency in Africa. Why are we talking about Africa?
So when we
About
look,
this measles outbreak?
yeah, only as a basis of the data that we have to support vitamin A. That's it.
Okay.
Yeah,
'Cause again,
that's our basis of data for that particular intervention, and that's the only association there.
okay, again, you're talking about something else. You're not talking about this measles
Yep.
outbreak right here,
Correct.
right? And then finally, peer review, because we were talking about whether you want, Rep. Simmons brought up, you want to make sure like, I'm not going to talk about chiropractors like you just said, but you want to make sure that whatever information we share with the public is scientifically based, correct? And peer review is one of the ways that things are scientifically based,
Correct.
right? Because 2 + 2 always equals 4, and certain things have to happen a certain way. So any kind of speculation is just that, speculation, correct? It's speculation.
Yes. Speculation.
Right,
is
all right. I just
yes.
want to, for me, facts are important.
Yes.
Okay, thank you.
Yes.
Representative Pearson.
Thank you. I just had 2 points, 2 quick questions to clarify. First thing, going back to the same but different versions of MMR. Of those who have been diagnosed with measles that were previously vaccinated, are you tracking which version those individuals were given?
We are trying to. Well, our first initial data that we have and that we report is based on self-report. Then we have to go back and try to find the medical records or any record of that to try to ascertain exactly when that happened and what kind of vaccine was given.
Okay, great. And then you mentioned the Texas Administrative Code saying that the school administrator shall exclude the unvaccinated, but the rule 97.62 says that the health authority may exclude the unvaccinated. Can you clarify who really has that authority, and is it shall or may?
Sure.
You can get back to me if you don't have it.
I will absolutely. It's in
Okay.
another folder, but I have that with me, and we can get back to you quickly.
Thank you.
Absolutely.
Thank you. Representative Alcott.
I'd like to get back, I wasn't the one that brought up international travel, I think you were. I was talking about the influx across our southern border. It's been a huge surge lately. And is it So it sounds like you do not know where this originated, where it came from.
No, I don't.
So, international travel is speculation.
Yes,
Just, you think it's just a coincidence that we've had an enormous surge and measles has all of a sudden, popped up again? But let me ask it this way. Would you agree that it's very possible, had we not had such a huge surge in foreign nationals coming across our southern border, many of whom are unvaccinated against measles, that this may never have occurred?
I can only speak to history, and I can tell you, for instance, the 2018-2019 outbreak that happened in New York was enormous. It was one of the biggest we'd had in a long time. And that was an undervaccinated community of Orthodox Jewish people who had, at least one person had traveled to Israel and brought back and then seeded that community. And so I think we've seen examples of where it's not travel from our southern border, that it's other travel that just happens to get into a pocket of undervaccinated. And that's why I can't pin it on this. I've just seen examples of how it's happened in other ways.
Right. And I know you're not going to know for certain, but I'm just asking, would you agree that it's quite possible that would not have seen a measles outbreak had we not seen this enormous surge across our southern border?
I don't have any data that would say yes or no to this outbreak, because this has been going on in that community for a while. I mean, the falling vaccination coverage rates. And so, by itself, it was ready for an outbreak, and it would just take one person. So whether that introduction came from travelers there or travelers from other places, I don't have any data to say.
Okay. Sure. On a separate topic, can I ask another question? The marketing and promotion of the vaccines, is that primarily paid for by the manufacturers, or do you all also, does the state pay for some of that?
So we do vaccine messaging saying, if you want to get vaccinated, you can go to your local health department, or the local health department has these vaccines for you. So we do get some grant money to do that sort of messaging, just trying to get primarily school-age kids to get vaccines before the school year. No other, say, promotional or advertising happens on
Sure. Do the manufacturers spend any money on promoting that and marketing it?
It's an assumption on my part. I assume so.
Yes.
But I don't know what those numbers look like or anything.
I was just wondering if you knew and if that was, you thought would be sufficient. I mean, and how much do you think the DSHS spends on marketing vaccines?
So it would just
on all vaccines
be our public health messaging, and some of that would be through grants that we get from CDC. And so we can get back to you.
Okay.
I don't have any of those numbers on the top of my head.
Thank you.
Sure.
Representative Schaffner.
One quick question. You said under-vaccinated. Does that mean they just got one dose, the 93% coverage, versus two doses, the 97% coverage?
Right. And so being fully vaccinated depends on, I think Representative Johnson brought it up earlier where, when I was a kid, one dose was recommended. And so those people would be considered fully vaccinated. But say there's a 10-year-old in school that's only had one vaccine, they didn't get their second recommended vaccine, then we would call them under-vaccinated. They weren't fully up to date on that vaccine.
Right. So under-vaccinated would mean one dose, which would mean 93% coverage.
Correct.
Okay, thank you.
Representative Simmons.
Thank you, Mr. Chairman. I just want to get clear, because I hear a lot of different things about the border and it entering. Eradication doesn't mean it's completely gone. It's just that it's a very, very low prevalence of the disease that can be spread. And when we have the levels of vaccine rates, that it pretty much means it's disappeared. But there is a chance that it could have just been floating around here in the country already, and it made it into one of those under-vaccinated pockets, and that's why it's spreading the way it is. It doesn't necessarily have to be because someone from out of this country, regardless of how they got here, spread it, right?
Yeah, that's absolutely correct. So the elimination title just means that we don't have it spreading starting in the year 2000, it was considered eliminated because it's not endemic. We don't have people in the United States without an injection from somewhere that's causing outbreaks. And so we had made it to a level where we weren't, a level of immunization coverage where we weren't having outbreaks. We might have one isolated case, but it wouldn't then go into an outbreak. And so that's kind of that definition. But certainly, a measles case from anywhere, whether it's domestic or international, could seed a pocket of a community where there's less than herd immunity, and there could cause an outbreak.
Thank you so much. And just for the record, I want to clarify, I do absolutely believe that chiropractors are real doctors. My frat brother, who I love very dearly, Dr. Lawson Howard, has taken care of our family for years. So I just want to, was trying to draw a connection between having a level of expertise in one area does not always translate or correlate with expertise in another area. And just a brief example, my daughter has sickle cell. I talk about it a lot. And she was on an antibiotic until she was 5 years old. That's just the protocol, the treatment. And I had a family member who is a dentist say, well, what about her immune system after she turned 6? And he was, kind of really concerned about her immune system not being strong enough. And I was just like, you do a really good job on teeth, but I'm going to trust the pediatrician that prescribed this methodology for her. So that's all. I just wanted to be clear on that. But thank you for answering.
Thank you. Members, any other questions? Dr. Schuford, thank you so much. Oh,
Yes,
thank you for your testimony.
Yeah.
Do we have anything else? Okay. Thank you for your testimony, for the information.
You're welcome.